Great, thank you so much. As noted, I'm going to dive into a little greater depth with the technology and then move into introducing the now started Reflect trial. So Triguard 3, as Jeff briefly shown, is similar in principle of operation to the original Triguard HDH device. Namely, it's a cerebral embolic protection device that's entered from the femoral arterial access, contralateral to TAVR device, and sits in the aortic arch in a dome configuration, providing complete 3-vessel coverage throughout TAVR or similar structural heart procedures. There have been a number of very important iterative improvements. The engineers have really done a great job in responding to the clinicians and improving this new generation device. The device is a nitinol self-expanding device. It's self-stabilizing now without the need for any interaction with the innominate artery itself. It goes through an 8 French sheath, which is basically a PCI sheath that all of us interventionalists are very familiar and feel safe with. The filter unit itself is shown here. Again, it's a dome-shaped PEEK mesh. It's readily visible due to the nitinol frame on fluoroscopy, and I'll show some images as we go forward. The filter size has increased a fair bit. It's now 3-fold larger. The pore size is smaller, but maintaining 60% open area and with an antithrombotic heparin coating. This is the new integrated delivery system. It includes an 8 French sheath. It's pre-assembled. There's a nitinol shaft, a very soft atraumatic tip that's delivered in an over-the-wire fashion to the deployment position. There's an integrated port to allow entry of the pigtail catheter from the same access. This is the blister pack in which it arrives. It's an extremely easy preparation, just takes a minute or two. Simply fill it with saline, flush the device, and sheath it prior to delivery into the body. The sheath device is shown here. Again, it can go over a stiff wire. Given this new over-the-wire configuration with this sheath, we are able to treat much more tortuous and difficult iliofemoral arterial access. And I've shown here some images from the core lab of access that we have successfully now treated with this device. Similarly, because of the improvements in the filter unit itself, it's relatively anatomy independent. No interaction with the innominate, very few anatomic exclusion criteria. And again, examples of challenging arch anatomies that we've successfully treated with this new device. And so I'll show a brief animation to give you a flavor of how this works. Wire access, the device is then advanced, as I said, over the wire from the contralateral femoral. It's 8 French. You advance 2 to 3 centimeters beyond the ostium of the innominate artery, and then by simply moving your hands, unfurl the device, it's self-positioning in the arch. Once it's in place through the same access, you advance your pigtail catheter to facilitate the TAVR procedure, and then the TAVR device itself. Once you're there, you perform your TAVR in the normal fashion. You then withdraw and easily recapture the device in the descending aorta. So that's the technology. I want to then move on to some of the clinical studies. This is the early feasibility study, 7 patients treated by Dr. Kerner in Rambam in Israel, as well as Joseph Rodas-Cabot in Quebec City. The first in man, as noted at the bottom, was just published this month in Eurointervention and is available for everyone's review. That takes us then to the Reflect trial. As most are likely aware, this is a prospective, randomized, multi-center safety and efficacy trial testing TAVR with versus without cerebral embolic protection with the Triguard devices. The leadership of the trial, many of whom are on the panel, Dr. Moses is the chairman, Alexander Lansky with very important contributions, and all the rest. Phase 1 of the trial utilized the Triguard HDH device that was completed after the enrollment of 258 patients. And with the availability of the new device, we've now started phase 2 of this trial. This is Triguard 3 versus control, 2-to-1 randomization scheme. There's the availability of poolability of the control groups for comparison to intervention, a total of 275 patients in that arm. These are the endpoints of the Reflect trial. There's a primary safety endpoint that's a combined safety by VARC2 definition at 30 days. This will be a non-inferiority test in the ES-treated population and utilizing a performance goal. In contrast, the primary efficacy endpoint will be a superiority test in the randomized intention to treat population. And this is a hierarchical composite efficacy endpoint consisting of death and stroke, 30 days, NIHSS, which is the stroke scale worsening post-procedure, and finally, DW-MRI lesion-based endpoints. The inclusion and exclusion criteria are extremely broad, such that will be broadly inclusive of essentially the majority of all patients undergoing commercial TAVR in the United States. The clinical exclusion criteria are minimal. It's simply use of an alternative, basically a transthoracic access route, valve-in-valve TAVR, recent stroke, or contraindication to brain MRI. The anatomic exclusion criteria have also been minimized with the new engineering advances. Specifically, it's just severe peripheral arterial or aortic disease that precludes delivery of the sheath, and very heavy calcified disease of the aortic arch or tortuosity. The REFLECT trial, as you are likely aware, has now begun. We're blessed with a really great group of investigators, many of whom are represented here. We have Dr. Abhijit Doble, who's really led the charge with enrollment out of the gate, and the sites are shown here on the map. All of the cases submitted to the trial are analyzed through the CT Core Laboratory. Rahul Sharma's here as well, based out of Cedars-Sinai. There's a patient review committee looking at each of these, and we've seen, again, speaking to the broad inclusivity of this, an approval rate well more than 90% in the early going of this trial. Again, the total trial is 275 patients. There's a 2-to-1 randomization that's stratified by intended valve type. At this point, we're around 70 patients enrolled, 45 of whom have been randomized in the trial. Based on this enrollment pace, we're anticipating completion of the trial in Q1 of 2019. So that's the trial. I wanted to finish by whetting your appetite a little bit by showing you what this looks like for the clinician, and we'll have other clinicians as well presenting their experience. But the procedure itself is quite simple. There's an arch angiogram shown to the left. You then advance the device up and very simply unsheath it, deploying it in the arch. And you see how readily visible this is on the fluoroscopy. And I've provided here several different projections, the LAO really spreading out the arch, or RAO down the barrel. And you see the enhanced visibility of this device, which is really something that's very important, I think, for the clinicians. I'm going to demonstrate a case of an Evolut R TAVI then. Once the device is in place, the pigtail, again through the same access, comes up and over, and then the Evolut R device itself. And we see here the Evolut R traversing the filter in a very facile, easy fashion. Once you're in the ascending aorta, it then becomes a routine TAVI and really allows you to concentrate on that primary procedure. Once you're done, simply withdraw it. You can then go ahead and perform any BAVs or other associated procedures while maintaining the cerebroembolic protection. Then once completed, you remove this by simply pulling it back and resheathing. You're then left with an 8 French access point that you can continue to use for things like a crossover, balloon occlusion technique, and iliofemoral angiogram, etc. Again, fitting very, very well into the TAVR procedural flow. I won't belabor it by showing another whole case, but just to speak to the fact that this is really possible and works well with all of the available commercial systems, Sapien 3, and I think others will also be presenting their experience. So I'll conclude by saying this new improved Triguard 3 device continues to offer complete 3-vessel cerebroembolic protection for our TAVR procedures. However, it's really been optimized for safety, efficacy, generalizability. It's very easy to use. We're underway now with REFLECT Phase 2, and we're expecting completion in early 2019. We've demonstrated already very high rates of anatomic screening success, and we're very excited about moving forward with this important trial. Thank you for your attention.